Well, it makes sense, with BCL2 inhibition that we're going to see this strategy being used in other cancers, and we know that it's already been approved in AML, and we could talk a little bit about that, in other heme malignancies, and maybe someday outside of that. But before we get to the future of BCL2 inhibition, in CLL, what do you think are some of the challenging issues, unmet needs that remain out there? You keep mentioning older patients, but what else?
Absolutely. We no doubt, Harry, I think the next frontier in the treatment of patients with CLL, that as you know, we can really improve the survival, but as we speak, right, is how to restore the immune system, because those patients still may be amenable to really have infections and secondary cancer. Recently, another publication about the incidence of secondary cancer with these new therapies. We know those patients per se, they have a high tendency to have a secondary cancers, right? So are those drugs can increase that, or just really allow them to live very, very long period of time where the disease really still produce severe immunosuppression, who really predisposed to have infections and cancers. So I think it's the next frontier, how to restore the immune system of these patients so they can have a better lives, and again, may really continue to really enjoy these very prolonged periods of remission, but without this complication that unfortunately happen very, very often in this older population.
Well, I think we're all excited about looking at BCL2 inhibition and other malignancies, and what we do, heme malignancies specifically. Sure. But there was a recent safety signal noted in a myeloma trial. Sure. Can you tell us more about that?
So what we read from the news, obviously, is that the trials, we knew at least, we heard and we have seen the very, very tremendous efficacy in subgroups of myeloma with venetoclax. However, it seems like the FDA really saw some safety information or safety data that really decide to put on hold these trials until more information is generated. I think it's something that it needs to be evolved. Obviously, patients with multiple myeloma has many other options, but definitely I heard and I saw in our practice for some of my colleagues who really see this drug, that the drug is quite efficacious. So how to use it and how to avoid these safety things is something that obviously they have to be studied very well to make sure that patients are safely treated.
But as I remember the survival curves that were presented that led to the FDA hold, they continue to diverge, so it doesn't appear to be a tumor lysis event right at the beginning. Absolutely. It's something that's happening later.
That absolutely, and this may be also related to complication, maybe infections complications of many other things that need to be taken into consideration, because we now, as we discussed, neutropenia can predispose to infection, and it's something that we need to be aware of and really deal with.
Any other BCL2 inhibitors that are coming forward that you know of?
So I think the next generation may really comes with the MCL1 inhibitors. I think it's fascinating. We believe that these drugs come in and they don't have any problem. For sure, we know that one of the classical reason why BCL2, in this case venetoclax, may fail in the long run is because two reasons. Because they are BCL2 mutation that was described last ASH meeting, right? And I have the opportunity to see a couple of cases, as well the upregulation in the lymph nodes of MCL1 and BCXXL. Other anti-apoptotic protein that can really compensate the blockade of BCL2. So I think in the future we're going to see, different combination even with other anti-apoptotic protein blockades.
Now, you're the section chief for lymphoma, other lymphomas, B-cell lymphomas, where this is being
Well, it's very
used?
very interesting, because everyone was predicting a very, very high efficacy in follicular lymphoma, and as you know, well, the data have not been as striking as we really thought, considering that BCL2 is very, very upregulated. Different reasons we still don't understand very well. Definitely there is a role in some of we now, for example, in mantle cell lymphoma is studied very well in combination alone. So I think it still need to be said how the BCL2 are going to be used maybe in combination with chemotherapy. There's many trials that are addressing that, and maybe in different subtypes who really specifically see, as happened with the BTK or BCR inhibitors. We know ABC subtype, it may work more, but maybe in lymphomas, we need to understand which are the patients who may be more candidates to these drugs.
And as you know, there's been a recent update to the label of venetoclax to include AML.
Sure.
Very exciting data from the phase 1b studies of older patients with infirmities and comorbidities that lead to them not tolerating chemotherapy. The combination of HMA with venetoclax or low-dose Ara-C with venetoclax have produced very rapid and very high response rates. HMA venetoclax, 61% CR, CRh, 70% CR, CRi. Very rapid time to response. And the duration of responses seems significant, on the order of a year, and median survivals of over a year, 15 to 18 months, depending on the analysis that's been there. And as you know, those combinations are now in randomized clinical trials. We're awaiting the results. They've finished
very exciting
accrual.
Data for sure, and really a great alternative for our older population patient who may really increase his quality of life just to really put in remission, as happened in a very nice way without necessity sometimes to be in the hospital.
Well, we're appreciative to our colleagues in CLL who have prepared us for some of the issues that we are going to be seeing, like monitoring and prophylaxing for TLS, neutropenia. I think these things that these are things that we are going to have to deal with as we treat these patients with AML with a very effective regimen. So clearly a very active way of improving the outcomes of patients with hematologic malignancy, CLL, and now AML. Before we close, anything else that you want to leave our audience with?
Well, I think the future is extremely exciting for patients with CLL these days. We have more and more alternatives for treatment in the front line and the second line, and I think really blocking this important mechanism for which CLL persist and survive and proliferate are going to be crucial to really continue to really conquer the cure, at least this really long-term control of these conditions.